Welcome to the Drip Podcast. Today's guest is a clinical nurse specialist and a senior manager in global medical affairs at Baxter. She also practices in the cardiothoracic ICU at WakeMed Health in Raleigh, North Carolina. She received her undergraduate nursing degree from Wake Technical Community College and the University of North Carolina, and an advanced practice graduate degree from Duke University. She is active in the AACN's NTI Advanced Practice Institute Program Planning Committee and acts as a content expert and developer for the Essentials of Critical Care Nursing program. She was inducted as a Fellow of Critical Care Medicine at SCCM and also awarded CNS Entrepreneur of the Year in 2023 by the National Association of Clinical Nurse Specialists. She has always been drawn to the basics of nursing care, ensuring quality outcomes through education, data collection, and ensuring best practice standards at the bedside. Please welcome Lisa Soltis.
Hello and welcome to the Drip Podcast. I am your co-host, Clayton Grigsby, and I would like to say hello to our amazing host, Angela Craig, and let's not forget our awesome technical engineer and producer, Josh Siegel.
Woohoo! Thank you, Clayton. We have with us as well Lisa Soltis, who works here at Baxter as well. Lisa, welcome. Can you just share with us your current role here at Baxter?
Thank you so much for having me on the podcast, Angela and Clayton. I'm really excited to be here. So as you said, I also work here at Baxter. I'm a senior manager in global medical affairs for advanced patient monitoring. So basically, I'm involved with acting as a clinical voice for some of the different products, especially related to patient monitoring. So I'm excited to be here and talk about today's topic.
Awesome. So wonderful to have you. So let's get right to it. Today, we're going to talk about IV fluid conservation strategies. We thought this would be a good time to share with everyone who may be faced with the need to conserve fluids. We are here as a resource for product management and conservation strategies. We don't want this to be prescriptive, but there are some ideas to help you get through this time.
Yeah, thanks, Clayton. And I think it's important that we realize that a one-size-fits-all customer approach will not work at each facility or IDN because each facility and IDN is unique, right? And whenever you're thinking about the fact that you've come into this crossroads where you need to conserve IV fluids, then you need to implement aggressive conservation strategies immediately. Don't wait till the next scheduled operations meeting. You want to create a conservation team and or leader and really have changes to established processes. We know that sometimes those can introduce risk. So you definitely want to involve quality and risk management to ensure appropriate process controls and checks in all areas. So whether that's pharmacy, whether that's nursing, you want to make sure these decisions are made, as well with all parties. And then healthcare practitioners should use their own professional judgment in evaluating the information we're going to give you today and assessing the needs and resources of their individual organizations. Now, the way these strategies are set up are in three different categories. And just so you're aware, a big body of people came together and determined this. And it was from multiple walks of life. So pharmacy, nursing, providers, doctors, nurses came together to say, hey, if we came into a situation where we needed to conserve IV fluids, how could we go about and do that? So there are three strategies or categories. One is clinical considerations, two is operational considerations, and three is communication considerations. So we are going to start with the clinical considerations. And Lisa, do you want to tell us about some clinical considerations we might want to utilize if we're ever in this situation?
Absolutely. Thank you for the intro and kind of explaining why we're here today. So one of the more important aspects of looking at IV fluid conservation strategies is really making sure, as you mentioned, having a clinical team to kind of discuss what the current practices are and to see how we can potentially either evaluate those practices and see if there's any changes that we could make that would impact that. Part of that is important to have communication. And so part of that would be involving your P&T committee as far as your pharmacy and therapeutics committee. We want to make sure that anyone that will be impacted by that in an inpatient hospital setting is aware of any situations that may be going on, involving them so that they can have the opportunity to provide input and be able to discuss potential options as far as our conservation strategies with that. Also looking at including, our pharmacists and other clinical colleagues to make sure that, we've got all the information that we need as far as if we are short on certain supplies and different substitutions that could possibly be recommended as far as certain solutions such as, LR, normal saline, things of that nature. So involving that committee would be an important part of the process. Also making sure that all clinical providers are involved as well. So again, all the specialties that are represented, our physicians, nurses, especially our hospital pharmacists, advanced practice providers as well. So the NPs and PAs that are rounding on patients, making sure that they're aware of any, potential practice changes or any potential shortages that are currently being experienced in the field or in the environment there. Our OR colleagues, as far as our anesthetists and as well as our nutrition support team, and making sure that they're all involved in the process so that they have the opportunity to provide input and give feedback, and then agree to any suggested practice changes related to that. Another important consideration then is also looking at special populations found within the hospital setting. So again, looking at the ICU is always an area that tends to take priority just because we know the clinical needs are significantly higher for those patients that are critically ill. But we also have, special patients for many reasons as far as pediatrics and neonates. And their clinical needs and fluid needs are very different than what we see in ICU and what we see from adult patients. And so special considerations need to be discussed and, based on what those needs are and addressed as well. You also want to look at, if you're in a situation where, it's a short-term event, what is our contingency plan for that? And one of the discussions should be related to management of elective surgeries at that point. Is it possible to defer any of those elective surgeries to a later time, especially when it's a short-term event? And so we want to try and conserve fluids. And we know that, various types of surgeries are going to require a significant amount of fluids with that. Any potential to conserve stock, looking at rather than if they're setting up the OR, rather than just making sure that they're hanging all their fluids the night before so that it's ready to roll in the morning, assessing, do we really need to hang, 2 bags of fluid for each case that they're doing? Can we use a 500 bag versus a liter bag? So looking at small changes that all can add up and definitely change, the utilization and conserve some of those fluids. Also, something that we have a tendency to not utilize often in the hospital setting is using enteral fluid replacement versus IV and parenteral. So only reserving that for, necessary cases, and really looking at encouraging PO intake, using PO electrolyte replacements and other types of fluids for patients, considering decreasing the NPO time prior to a procedure. Does it need to be 8 hours, or is it okay to be, 2 hours, and allowing the patient to drink up until 2 hours prior to the case? So all of these little aspects of it can certainly impact and help conserve those fluids. And then again, maximizing PO meds so that we can, decrease and limit the number of IV meds that we're giving as well. also looking at the practice of starting IVs and just, in the mindset of, well, just in case we need to have an IV for our patient, let's go ahead and put in a couple. And then sometimes that then leads us to the next step of, well, let's just go ahead and start some maintenance fluids. Let's put it on KDO. Let's just make sure that they're, hydrated, that they've got fluids going just in case. And sometimes those fluids that we're giving aren't necessary. And not only do they contribute to additional work and time involved to the nurse or provider that's administering those fluids, but may not be necessary for the patient as well. Keep in mind also, when we give certain meds, we always piggyback them. And so we've got our flush bag, and then we've got the actual med as its secondary, and then we do the flush again. So can we look at other ways of doing that flush? Can we just, do a manual flush, with a couple syringes, and then start the medication and then flush again after without having to hang another 500 ml bag just to serve as a flush for our intermittent antibiotics or other meds that we may be giving, whether it's potassium or mag or some of these other meds that we do short term. Also looking at, assessments of our patient's hydration status, not only the intake and output, but a thorough assessment of the patient, as far as whether or not they're fluid responsive, whether or not they need those additional fluids that we're giving, just in case, or just because it's part of our protocol. We want to make sure that patients are getting what they need. And part of that is to customize our care and individualize it for the patient so that we're not just doing things for the sake of that's the way we've always done it, or it's part of the protocol, but we're actually assessing to see, does this patient really need those additional fluids? And then also, patients that are receiving fluids, what are the rates that we're, administering those fluids, and can we use smaller bags and lower rates for those patients also? The other thing to think about as well is looking at, standing policies for, how you change out your IV fluids, your tubing, your bags. It's important to follow, professional guidelines as far as, the Infusion Society, our ASHP, as far as our hospital pharmacists and things. And so we do want to make sure that we're following best practice, that we're following appropriate guidelines to help decrease risk, decrease in potential infections and things like that. But looking at, is it, possible, as a short-term fix or, short-term option is to look at, how often are we changing those bags or changing the tubing and things like that. So you want to try and maximize the fluids that we are spiking, that we do have, without, necessarily being wasteful. And so, again, spiking a 500 bag, for 3 or 4 days, but then we're not going to be using those fluids. Is it possible to use a smaller bag, a 250 bag, things like that? So looking at how can we maximize what we have and not be wasteful from that perspective. The other thing that also, really makes me think too is about the amount of biological biohazard waste that we create also with all of our plastic bags and plastic tubings and everything that we're utilizing, and is it really necessary? And so from a not only a fluid conservation but also a waste conservation, can we decrease the amount of supplies that we're using and wasting and throwing away, I think is another important aspect. And then I know it's, a lot to think about, but also looking at any standing orders, any standing policies, evaluating those to see, can we make any revisions to those or adopt some changes to help decrease the utilization of unnecessary fluids with that. But, you have to look at all the aspects that, we put things in place, policies, protocols, order sets to help improve the workflow. But in light of, a short-term change in practice or a shortage of, fluids or conservation strategies need to be implemented, that's one of the things you can look at is to see, what is in place and can we make modifications to that, whether it's a long-term change or if it's just a short-term to address the critical need, during a short-term event with that. I know that's a lot to think about, but there are so many aspects to our care and so many people that are influenced by that as far as our colleagues in all the different departments. And so, again, communicating with each other and looking for ideas to help with conservation strategies certainly can help your efforts with that.
Yeah, thank you, Lisa. That was really a good refresher. And I had times I wanted to pipe in and say, yes, that's so great. That's so great. But in lieu of time, this is a little longer podcast because there's so much to cover. You were on a roll. I just let you keep going. I think yeah, I think some things just I usually like to banter back and forth, right? It's kind of fun to do that, but we do have a lot to cover. But there are just a few things too that I wanted to kind of hone in on. And you had mentioned one of the things whenever you're changing practice, how important it is that you look with your group and make sure it's safe. And I love that you said that. And I think it's important to remember always to include your infection control in those as well as your quality people so that we can make sure, we come up with some great ideas, but just to make sure we've got that double checked with infection prevention and with quality to make sure we're all thinking correctly.
Absolutely. Yeah, that's a fantastic point, especially our infection control people, just to make sure that, if we do implement any changes in practice, that it's not going to create any unnecessary risk to the patients.
Absolutely.
Yeah.
Absolutely. So important. Another area I thought of just real quickly before we go into the operational considerations was home infusion patients. When we talk about if there's ever a reason to think about conservation strategies, we've talked a lot about the inpatient, but there are a fair amount of patients who get maybe dialysis at home or home infusions. And so, really, when we're thinking about this, let's not forget those subspecialties as well. So, when we think about operational considerations, you want to centralize stock and stock management for better control. You want to try to minimize stock, POC stock as much as possible, maybe removing those slow moving items. Just coordinating pharmacy compounding activities to minimize volume remaining at the end of the session. Now, I'm not a pharmacist, but those of you who are pharmacists or who are compounders, these are just some suggestions for you. Avoiding prep of medication made in bags of greater than or equal to 250 mils until the time of administration. As far as nutrition compounding, try not to discard bags of D70 and SWFI at the end of PN compounding day. Use those maybe to make solutions for the next day or starter bags for your neonates. For the pediatric and neonate Source dilution bags, if these are typically made as 250 or 500 mil bag, maybe consider switching to multiple 100 mil bags. If you can ever use commercially available pre-mixed medication for products that are typically mixed in 250 mil bags or greater, that might be helpful. Avoiding waste from partial infusions. So really trying to assess if the infusion may be discontinued shortly after the new bag was hung, communicating, with that prescriber. And we're going to talk about communication tactics next, but communication is really key in situations like this. If supplies permit it, use those smaller IV bags for infusion with slower rates to help decrease waste. And then restricting low supply critical codes when no alternatives are clinically appropriate to priority patient groups. So consider restricting usage of lowest supply products, sizes to the most vulnerable populations. And then be prepared with alternative options for infusion, diluents. Evaluate that drug and fluid compatibility for drugs where switching the default recipe may be appropriate. Maybe like something like what drugs are normally prepared in 0.9 that can be put in D5W or vice versa. And then secondarily, consider IV push administration rather than dispensing in bags when clinically and concentration appropriate. If small volume bags like the 50 mil or 100 mils begin to run short due to increased reliance on them. Now, consider IV push administration rather than dispensing in bags when clinically and concentration appropriate. If small volume bags like a 50 mil or 100 mil bags begin to run short due to increased reliance on them. Now, I always want to mention before we go on to the communication that, you have to also look at risk benefit balance. And so if you're giving something IV push and you're going to have to then train the nurses because they're used to giving it in a bag, making sure the concentrations are appropriate. But this can be done very safely. In fact, Lisa, you and I were just talking yesterday about when you still work at the hospital as well. And didn't you, and you there was a situation that came about where you actually did something IV push antibiotic wise rather than in a bag. So was that difficult or did you have to have training on that?
So I work in an ICU per diem, and so luckily our pharmacist, is there in the unit. And so when my ANSEF came up with a couple vials with the little saline vials in the bag with the unconstituted drug, and I just checked with the pharmacist, and she said, "Yep, just make sure you reconstitute it this way, push it this way." And the instructions actually were on the label of the plastic bag that everything came up through in the tube for. And so it was very easy, and made me realize that all the times that we've hung, as far as the have it going over, an hour or 30 minutes, and within 5 minutes to be able to administer and still have the same therapeutic effect for the patient, I thought was something like, why haven't we done it this way before?
Yeah, it makes us think differently at times.
It
So that's
does.
great.
Yep.
Well, wow, I have talked a lot. And so I would love to hand this over to Clayton. Clayton, can you speak to us on communication considerations?
Absolutely. Important to ensure frontline clinicians and other staff know what's going on because really they're the ones who really can make or break any conservation practices. We need to clearly communicate strategies with all impacted staff, provide frequent and consistent communication. That is just really key there. This can be done through electronic newsletters, screensaver reminders on hospital computers, EMR instructions, be as detailed as possible if you can. Here's what we currently can't get, for instance. Here's what we can get, for instance. Here are the specific instructions on what we are going to do about it. So these are kind of some questions and some statements we need to be making on these multiple media that we can definitely use. Consider when a patient communication may be necessary. As you said, home care, patients made aware of product packaging changes. Well, I know it's been a longer than normal podcast. Does anyone have any other ideas that or they would like to share before we close?
Clayton, I would like to mention the use of stroke volume guided fluid management. Um, when we do dynamic assessments, you can utilize passive leg raise or a fluid bolus to determine if your patients are fluid responsive. And I think that we could utilize more passive leg raises if the patient is able. And then we would be able to not utilize the fluid for the fluid bolus. I call it the poor man's fluid bolus. I mean, it's free, right? It's the it's the volume that's in their lower extremities that goes back to their heart. And then if they are not fluid responsive, we can lift their head and lower their extremities and it's reversible. It can go back where it came from. So I just think that's an opportunity for us. And then also not only for the fluid conservation, but then to know, hey, do these patients really need that volume. So to know for sure if we are going to give them volume, are they going to be responsive to it? So I think that's important.
I agree completely, because many times we're giving fluid just for the sake of giving fluid, or we're giving fluid because it's part of our protocol. And sometimes that assessment of need gets lost in the process. And so, being able to highlight the importance of that, I think, is critical.
Yeah, I think it's great. Well, it has been a great discussion, and we really hope this is helpful to anyone who may find themselves in a position where they need to conserve IV fluids. We hope that everyone has a great day, and we are glad that we can help support that mission of Baxter to save and sustain lives. Have a good one, everyone. Thanks, Lisa. Thanks, Clayton.
Thank you.
Thank you.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.